Welcome to the deep dive. We know you want to get smart about important topics quickly and thoroughly.
And that's what we aim for. Today, we're jumping into the intensive care unit, the ICU.
Right. Specifically, how artificial intelligence, AI, is starting to play a role there.
It's a pretty fascinating area. Lots going on.
Definitely. So we've pulled together some really interesting material. There's a research paper on using machine learning for early prediction of respiratory failure.
Which is a major focus for us today.
Exactly. We also have ICU guidelines, stuff on hemodynamic monitoring, an ICU manual, even studies on patient satisfaction.
And some papers looking at the bigger picture, too, like the data revolution in critical care and the future of the field.
Yeah, and we even have this bar graph showing what outcomes researchers actually, look at in ICU studies.
Give some good context.
So our mission today, really unpack how AI is being used or could be used as an early warning system. That focus is on predicting respiratory failure.
A really critical condition in the ICU.
Okay, let's dive in. Why is predicting respiratory failure early? Why is that such a big deal in the ICU?
Well, it's unfortunately quite common for ICU patients. And it's serious.
Right.
These patients are often very complex. Their condition can change really fast.
And there's just so much data, right? All the monitors.
Exactly. Heart rate, blood pressure, oxygen levels, respiration rate.
Yeah.
It's constant, a huge stream of information.
Yeah.
And for clinicians, trying to process all of that, spot the subtle warning signs before a crisis hits, that's incredibly challenging.
It's like finding a needle in a haystack, but the haystack is on fire and constantly growing.
That's a pretty good analogy, actually. Yeah. So timely analysis is tough.
Okay, so the solution being proposed in this paper is an early warning system, or EWS, using machine learning.
That's the one. The idea is to predict moderate to severe respiratory failure.
And the key is early, right?
Yeah.
How early are we talking?
Up to 8 hours in advance. That's the goal.
8 hours. Wow, that seems significant. What does that actually mean for the doctors and nurses?
It means time, crucial time.
Okay.
The system was trained on a really large data set, high read-to-Q, over 60,000 ICU admissions.
To 60,000, that's a lot of data points.
It is. And from a tertiary care ICU, so these are the really complex cases.
Right.
So the potential benefit is clear. An early alert gives the clinical team a chance to reassess the patient.
To maybe tweak the treatment plan.
Exactly. Adjust treatments, maybe intervene before the failure fully develops, or at least lessen how severe it gets.
And the paper says the alarm often goes off hours before it's clinically obvious.
Yeah, that's a key finding. That window could really change outcomes, stabilize the patient rather than react to a crash.
So let's get into the weeds a bit. How does this AI actually work? It's not just looking at oxygen levels, I assume.
No, it's much more complex. The system uses, I think it was 25 different clinical variables.
25. Right.
Yeah, a comprehensive set. And they contrast this with some earlier work. Well, they mentioned one study, Ding et al., used a random forest classifier, basically a type of machine learning model.
Okay.
But it only used data from the first day in the ICU. It wasn't real-time prediction.
I see. So less useful for moment-to-moment changes.
Right. And another one, Kim et al.'s fast-paced system, it used an LSTM, which is good for sequences.
Like tracking data over time.
Exactly. But it only used 9 features, 9 variables.
So the idea here is that more data, more variables leads to a better prediction.
That seems to be the premise, yeah. A more complete picture.
Now, you mentioned oxygen.
Yeah.
Getting the partial pressure of oxygen, PO2, that usually means arterial blood gas tests, ABGAs, right?
Yeah.
Which are invasive.
Yes, and you can't do them constantly. That's a major hurdle for continuous monitoring.
So how did they get around that?
This is quite clever, actually. They developed a non-parametric model. Think of it as a flexible way to estimate PO2.
Okay.
It uses the SpO2 readings. That's the oxygen saturation from the pulse oximeter on the finger, which is continuous.
Right, much easier to get.
And combines that with data from previous ABGAs the patient might have had.
So it learns the relationship for that specific patient.
Kind of, yeah. It allows for continuous estimation of the respiratory state without needing constant invasive blood draws.
That sounds like a big improvement.
It really is. And their model apparently outperformed the best previous methods for estimating PaO2 this way.
Which is great for the patient, less poking and prodding.
Definitely. It uses that readily available pulse oximeter data to give a near real-time view without the downsides of frequent ABGAs.
Okay, but systems like this can generate a lot of alerts. Alarm fatigue is a real problem, isn't it? Nurses get overwhelmed.
Absolutely. A huge issue in ICUs. So they thought about that.
How do they address it?
They built in an alarm silencing strategy.
Okay.
Basically, if an alarm triggers for a patient, the system won't generate another alarm for that same patient for 30 minutes.
I see. Gives the team time to respond without being bombarded.
Exactly. Reduces the noise, helps prevent staff from tuning out the alarms. They also use a specific evaluation method, event-based precision and recall.
What does that mean?
It focuses on how well the system predicts the actual episodes of respiratory failure, not just minute-by-minute accuracy. More clinically relevant, you know?
Got it. So does it predict the event, not just the number?
Yeah.
Okay. Now, what data points were actually the most important for the model? What did it rely on most heavily?
Good question. Their analysis showed the top 4 variables, in their more complex model at least, were, let me see, the current SO2.
That's the arterial oxygen saturation from the blood gas again.
Right. And the previous SO2 measurement, too. Also the PaO2 and the pH level from the last ABGA test.
Interesting. Still heavily reliant on those ABGA results then, even if estimated in real time.
Well, yes, for training and identifying importance, but crucially, for actual real-world use, the prediction relies on the estimated PO2 derived from the continuous SIPO2.
Okay, that makes sense. You train on the best data, but you predict using what's continuously available.
Precisely.
And is this just a black box? Does it just say high risk or low risk? Or can doctors see why?
That's another strength, they say. They developed a web-based tool for model introspection.
Introspection?
Yeah, clinicians can visually explore the input data, the predictions,
Oh, wow.
and even look at feature importance for a specific patient's prediction using something called SHAP values.
SAP values.
Think of it like assigning credit. It shows which specific vital sign or lab result is pushing the risk score up or down for that individual.
So not just high risk, but high risk because the estimated PO2 is dropping and the heart rate is rising.
Yeah.
Something like that.
Exactly. That kind of insight. It builds trust and helps clinicians integrate the AI's output with their own judgment.
That seems incredibly important for adoption. You can't just trust a black box with critical decisions.
Absolutely not. Transparency is key.
So, linking this back, our ICU manual source stresses how vital, accurate, timely information transfer is. This EWS seems like a perfect example of technology aiding that.
It does. It helps automate the analysis of that overwhelming data stream, flagging things humans might miss, especially when they're juggling multiple patients, like an AI co-pilot.
A co-pilot watching the monitors constantly. Now, this system is focused on breathing, but ICUs monitor so much more, right? What about circulation, hemodynamics?
That's right. This EWS is specific. But other guidelines, like the ISCCM ones on hemodynamic monitoring, are crucial too. They talk about assessing peripheral perfusion.
Like checking if hands and feet are cold.
Sort of, yeah. Temperature gradients, capillary refill time, CRT, signs that blood flow might be compromised.
Which this EWS doesn't predict directly.
No, but it's part of the overall picture of a critically ill patient. And the ICU manual lists tons of other things tracked constantly. Blood work, temperature, fluids in and out, blood sugar, weight.
It's a whole constellation of data points.
It really is. And maybe a concerning respiratory prediction combined with poor perfusion paints an even more urgent picture for the team.
Okay, so this ties into the idea of the data revolution in critical care that one of our sources talks about. What's the main takeaway there?
The core message is that this explosion of big data in the ICU vitals, labs, notes, treatments, everything, it holds immense potential.
Potential for what?
To personalize care, create better risk scores for individuals, discover new knowledge about diseases, optimize how the ICU functions.
Making decisions more efficient.
Yeah, or allocating resources better. It also mentions combining data from different sources, notes, numbers, images, for a more holistic view.
And maybe catching errors, like if the numbers don't match the clinical notes.
Exactly. Built-in sanity checks. Ultimately, good data helps standardize the best practices and reduce unwanted variations in care.
So this leads us towards the future. What does the future of critical care article envision? It sounds pretty high-tech.
It really does. It paints a picture of AI algorithms, wearable monitors, and telehealth centers all working together.
How so? Give us an example.
Okay, imagine someone recovering from flu at home. Their wearable sensor picks up a subtle drop in oxygen. An AI flags it, triggers a telehealth consult with a critical care specialist. Maybe a drone even delivers an initial treatment or a better diagnostic tool.
Drone?
Yeah.
Seriously?
That's the vision. And if they worsen, a mobile critical care team comes out, already armed with data, providing advanced care en route to the hospital.
Wow. That's blurring the lines between home, transport, and hospital care.
Completely. And it goes further. Personalized treatment based on, well, everything. Your individual immune response, the pathogen specifics, your genetics, how you're responding to drugs right now.
Real-time personalized medicine.
Pretty much. And the ultimate goal is these learning healthcare systems,
Meaning?
where anonymized data from lots of hospitals is pooled securely.
Oh, yeah.
Then you use that massive data set to constantly refine treatments, improve equity, spot pandemics early, design better clinical trials, manage resources during emergencies.
It's using collective experience on a massive scale to improve care for everyone.
That's the idea. A much more proactive, data-driven system.
Which brings us to a crucial point. With all this tech, what outcomes should we actually be measuring? Our last source tackled this, right?
Yes, the review on what outcomes should be evaluated. It's a really important question.
And the main point is,
it highlights a shift towards patient-centered outcomes, things that matter directly to the patient and their family.
like,
Survival, obviously, but also quality of life after the ICU stay. Functional status, can they go back to their normal activities, live independently?
as opposed to just focusing on disease metrics.
Exactly. The traditional focus might be on, say, days off the ventilator or changes in lab values, disease-focused outcomes.
And the problem is that improving those doesn't always mean the patient is actually better off in the long run.
Precisely. A treatment might shorten ventilator time but not improve long-term quality of life, or even worsen it in some ways. There can be a disconnect.
And that bar graph data we have seems to reflect this. Lots of studies look at things like ventilator days.
Yeah, you see mortality being tracked, which is patient-centered, but also significant focus on mechanical ventilation days, nutrition markers, sepsis rates, those more disease-focused metrics.
Why is it hard to measure the patient-centered stuff long term?
Challenges exist. Patients get lost to follow up after discharge. And the tools used to measure quality of life or function aren't always standardized, making comparisons difficult. But the key takeaway is this gap. What often matters most to patients isn't always what researchers prioritize or find easiest to measure.
It's a critical reminder, isn't it? As technology gets more powerful, we need to make sure it's serving genuinely human goals.
Absolutely. Keep the patient experience front and center.
So, summing up, this AI early warning system is just one example, but a powerful one, of how tech could transform critical care, giving clinicians these timely, data-driven insights.
Right. It showcases how we're leveraging data in this high-stakes environment, aiming for better care, better outcomes.
And it really makes you think about the broader picture of AI in healthcare, doesn't it? How will our understanding of critical illness change as we get better at collecting and analyzing all this data?
It's bound to evolve.
And the big question perhaps is, how do we ensure that as we advance, the outcomes we measure, the goals we strive for, truly align with what matters most to the people at the heart of it, all the patients and their families?
That's the crucial challenge moving forward, making sure tech leads to more humanistic care, not less.
Definitely something to keep thinking about. Thanks for joining us for this deep dive.